Thank you very much for Oncology Club and organizers of the conference for the invitation. First time in Bangladesh, and I should say greetings from my dad. So people will always ask wherever I go. So I was born in the UK to a father who's from Punjab and a mother who's from the Caribbean, but whose family originally from India. So I don't look Indian. I don't look South Indian. I don't look North Indian. So nobody knows where I'm from. But my dad was so happy when I said to him that I'm coming to Bangladesh, because after partition, he came to West Bengal and grew up here. So he's very, very happy. So greetings from my dad. So this is what we're going to talk about, integrating palliative care into oncology in low middle income countries. Which shall I use? Slides. Okay, so I'm a palliative care doctor, so I'm generally more comfortable with dealing with uncertainty and dealing with the grayness that we tend to have in life. There is a fundamental truth of human existence that we're all mortal. We're all going to die at some point. And this is not meant to be morbid. This is simply reality of what it means to be human. And why is this important? Because not everybody that we treat for cancer will survive. This is not a new thing. This is not a new concept. This has been around for a long, long time, all the way to antiquity, to the beginning of religion, and this is being rehashed nowadays. I'd encourage everybody to read Atul Gawande's Being Mortal if you've not done so already. And I'll also encourage you to read these two little books that I've got here. Gratitude is written by Oliver Sacks, who's a neurologist or neuroscientist who died not that long ago, but once he was diagnosed with metastatic cancer, he wrote this book, and it's a series of very, very short essays on being thankful for the life that we have. Very, very quick to read. It takes less than an hour to read, but beautiful sentiment. And likewise, this is one of my patients, Simon Boas, who died from esophageal cancer, and he wrote a little book about a stoical approach to death and dying. Why am I putting these things up here? Because if we, as the physicians and the clinicians, are not able to deal with the high emotion typically that comes when patients are approaching the end of life, we're never going to be able to figure out what's important to them. So I just put these slides here to set the scene. So why am I talking about palliative care? So Bangladesh has more than 200,000 new cases per year. I'm sure my data is out of date already. Now, 70% of most of the cancer patients in low middle income countries come with an advanced stage illness. I work in Abu Dhabi in the UAE, and interestingly, we get 40% of the patients who present to us come with stage 4 disease. At least that's certainly what we see in our center. And it matters because the symptom burden is very, very high. And if the symptom burden is very high, then quality of life is also affected. This is ChatGPT's definition of palliative care, and I put this in because everyone has talked about AI so far. I'm not going to talk about AI. This is as much AI as I'm going to cover. But this is a good definition. It's as good a definition as any. And it's basically relieving or minimizing health-related suffering and improving quality of life. And again, I'm just putting this slide for terminology. You know, there is a difference between palliative care, end-of-life care, hospice care. Hopefully we'll cover more of this in tomorrow's palliative care session. But suffice to say that all hospice is palliative care, but not all palliative care is end-of-life care. So the way to think about palliative care generally, and I don't think people would disagree, is that palliative care is really a continuum of support. The graphic on the top is, I guess, the old-fashioned model of palliative care, particularly alongside oncology. And the second graphic below is actually the more up-to-date version. This is not the only model. There are bow tie models and hexagram models, but this gives the idea. And so rather than simply treating a patient and giving disease-modifying treatment until it no longer works, you start giving palliative care input at the point of diagnosis, whatever the diagnosis. This is oncology conference, so we're talking about cancer, but it applies to things like motor neuron disease and heart failure equally well. This is taken from the recently published, as in the last couple of weeks, Palliative Care Atlas of Palliative Care Development. And Bangladesh and many, many parts of the world are still in this sort of progressing phase of palliative care development. Where I work in the UAE, I think we are even further down the ladder in terms of development. So Bangladesh is definitely ahead of us. So the main crux of the talk is evidence for integrating palliative care with oncology. So there was a seminal paper done, and it's now 15 years ago, by a team at Mass General in the US, and I think most people are familiar with this study. Essentially what they did was they looked at two groups of, or in fact one group of patients with stage 4 lung cancer, and they split them into two cohorts. One cohort had standard oncology treatment and palliative care input on an as-required basis, as the oncologist felt was necessary. The second group had standard oncology treatment, but on the day they were diagnosed, day one, they had palliative care input, and palliative care was given all the way through. And they followed both cohorts all the way through to death. And these were already patients with advanced stage disease. And actually, what it showed, and again, there we go, there's a slide, the palliative care at the start, very, very early integration, provides very, very good outcomes for the patients. And what does that mean? It means patients have better quality of life scores through validated measures. They've got better symptom control, better pain, less mood disturbance, better quality sleep. But what we also didn't expect to see is that these patients lived on average 3 months longer. So good evidence for early integration of palliative care. And this has been copied and reproduced with upper GI malignancies, non-malignant disease. We haven't reproduced the life advantage, the lifespan extension, but the outcome measures are very, very clear. If you integrate palliative care very early on, people generally do better. So I'm not going to go through a whole meta-analysis. It's in the literature. But the question is, why does integration matter? So we know that if patients are having oncology treatment and they have a proactive approach to managing symptoms, they'll have better symptom control and they'll tolerate their treatments better. If your patients are having radiation and their pain and skin disturbances are managed better, they will tolerate the rest of the treatment far easier. If you have palliative care early on, your communication and decision-making can be that much easier. And I'm not one of these palliative care doctors who criticizes my oncology colleagues. You know, everybody brings a different skill set to the table. And so the oncologists are going to focus on the cancer treatment, what we can do, what we can't do. They may not necessarily be as comfortable as talking to the patients about the uncertainty or the grayness or mortality. Fine, that's what we're good at, so let us work together. And actually, if you work together and everyone's on the same page and communication is clearer, patients and families make better decisions. We know that if palliative care is integrated early on, patients don't come to the ED as often. They have less inappropriate admissions to the ED, and therefore the health expenditure costs are reduced. And families cope better. So I spend a lot of time teaching and training junior doctors, and I often hear them complaining about having to speak to the families. And like, no, you've got it back to front. When the patients go home, who's looking after the patient? It's the family. You have to engage with the families. So a significant proportion of our time in palliative care is actually supporting the family, making sure they understand, making sure that they feel comfortable asking the difficult questions. The title of this talk is actually quite difficult. And I don't think 20 minutes will do it justice. So I've tried to summarize a number of the models. I've put the references at the end. There is no absolute one-size-fits-all. There are many, many different ways to integrate palliative care into oncology. And you have to do what is most appropriate for your local context. So if we take the first one, this primary palliative care by the oncology teams, ideally, you know, what you want is the oncologists and the oncology nurses providing inpatient care, for example, to provide those core palliative care skills, optimize symptom control, have goals of care discussions and basic psychosocial support. But if patients really, really complicated, then you escalate to palliative care teams. This assumes that you have access to a specialist palliative care team, which many parts of the world wouldn't. An alternative model is this sort of embedded in oncology, or sometimes people term this enhanced supportive care approach. So palliative care will start at the point of diagnosis. It runs in parallel, and you'll often have palliative care co-located within the oncology clinic. When I worked at Imperial, this is what we did. So we would always make sure a member of the palliative care team was in the oncology clinic, so we saw patients immediately. There was no waiting. Again, this also requires adequately staffed palliative care services. Then you've got trigger-based consult services. So there are very, very specific criteria that your oncology team would use to decide which patients need and get a palliative care review. This is helpful, and it makes predicting which patients need care, and it makes job planning and service provision easier. But again, if you don't have a specialist palliative care team, this is problematic. If you move a little bit outside the hospital setting, you can have nurse-led and non-clinician-driven, community-based, home care-driven palliative care. And you can train nurses primarily, but not exclusively, social workers, etc., to provide a standardized level of home care, and then you can escalate to hospital or other palliative care centers in the community. This aligns with some of the particular WHO goals, particularly along the lines of cancer control. This is very, very similar to what happens in many parts of the world, like with Pallium. They have a huge community palliative care network, which is not possible to reproduce this everywhere. You require a certain type of community. So for example, in the UAE, as much as I love what Pallium does in South India, we're not able to do that in the UAE. It may work better here. Then you've got hub and spoke and telemedicine and all of these slightly more higher tech ways of integrating palliative care. And again, people have already commented, there are specific resource requirements, good, stable internet connections, access to specialists, etc. So I cannot tell you what the ideal model is for Bangladesh or any particular low middle income country, because it will vary. You may well need a hybrid version of any of these things. I'm not going to go into all of these different models. Actually, this is the wrong slide. So one of the things that we see when we go through all of those different models in terms of how things are integrated is you can split parameters into barriers and enablers. Significant barriers to integrating palliative care, and none of this is rocket science. The misconceptions about palliative care, the myths about palliative care, and we'll talk about some of those just now. Opioid overregulation. So yes, many regulatory authorities are very concerned about opioids and controlled medicines being diverted, but actually the evidence for that is very, very low. And now we've got so much overregulation that it's actually limiting access to medicines for pain. Funding models, I'll talk about a little bit later. Excuse me, but your enablers, e-learning, advocacy, policy inclusion, local collaboration. You have to engage with the people who make the policy. If you don't, nothing will change. So recently the Palliative Care Atlas came out, and I know many, many countries in the Eastern Mediterranean, where the UAE sits, were unhappy with the way their countries were portrayed. The UAE had issues with the way things were reported, but actually we sat down with the federal regulators in the UAE, and actually it was a very, very fruitful conversation. All of their assumptions about palliative care were through the lens of oncology. And yes, we're in an oncology conference, but palliative care is not for oncology alone. So there wasn't recognition that actually palliative care is a standalone specialty. It can help patients with multiple diagnoses. So if you don't, the point is, if you don't engage with the policymakers and make things very clear for them, they won't know. It's not that they're malicious, but if they don't know, they can't change the system. So again, we talked about some of the myths that come up in terms of palliative care. It is not for cancer. So wherever there is health-related suffering, there is a role for doing something about it. Therefore, there is a role for palliative care. And the symptom burden in patients with a non-cancer diagnosis is not far off that you see in terms of cancer patients. So there's a huge amount of work to be done. I'm not going to run through every single myth. That's not the purpose of this talk. But the slides are there. You're very, very welcome to have all of these slides. But I am going to spend a little time talking about these. These are taken from publication within the last 5 years, references at the end. And basically what this does is it looks at the level of health expenditure, particularly towards the end of life. And we know from many settings that if you look at a patient in the last year of life, and then you look at the point of death, and you count backwards, so 1 month before death, 2 months, 3 months, and so on, you end up with this sort of exponential curve with health expenditure. So as you get closer to the end of life, you end up spending more, particularly in the inpatient setting. This is what happens in the last 6 months of life for inpatients on the top curve, and outpatients. So as your inpatient costs go up, your outpatient costs go down, because the majority of these patients are admitted. So giving some thought to how palliative care services are paid for is really, really important. The problem is if you don't give it some thought, what happens is many of these patients who end up needing end-of-life care, they end up staying in hospital. Now the problem is, or one of the problems, is that many parts of the world, including many low-middle income countries, you've got home, you've got hospital, and you've got not very much care in the community. There may be some primary care infrastructure, there may be some community services, but one of the things that happens is patients end up staying for very prolonged periods of time in hospital, blocking acute beds. The more community services you have, the more integrated community services you have, the less likely this is to happen. And the take-home message from this slide is, the blue curve is what happens when you don't have an integrated community-based healthcare system with palliative care included in that. And orange is what happens when you do. And so this is actually taken from a bit of work done by a group in Colombia, which certainly fits the criteria for a low-middle income country. And they've got a really lovely setup where their insurance or their healthcare service is a combination of some social medicine, but predominantly paid for service. So patients have to pay medical insurance premiums. But wherever they need the care is provided with no extra cost to them, whether that's the hospital, the hospice, primary care clinic, primary care family medicine doctor, and patients bounce in between, and the right care is delivered at the right time, in the right place, for no extra cost. This can be done, and given that medical insurance is here to stay, social medicine is decreasing across the world globally, we have to give some consideration to how we fund palliative care services. So what are the key messages? Early integration definitely produces better outcomes. It is feasible in low middle income countries because the argument to not do anything doesn't make sense. We can save money and give patients a better outcome, and palliative care does not mean somehow less good quality care. It means often less inappropriate medical interventions, which means less suffering. So how do you actually make that difference? I think you do have to integrate palliative care into every oncology unit, and it should be included in your National Cancer Control Plan. We are never going to have enough palliative care physicians and nurses. The last data I saw from the UK, where I trained, is that 40% of palliative care consultant posts are unfilled. There is a global shortage of palliative care trained clinicians, and we will never provide enough people for the global need. So actually, what's a more pragmatic and practical way is that we need to upskill our oncology colleagues, make sure that all oncologists are comfortable doing the complex symptom control, having those sensitive conversations. And we have to empower families, and some of that tips into societal death literacy and death awareness. As medical interventions have progressed and over time, patients and families' expectation of what modern medicine can offer is hugely disproportionate to the reality. So patients and families often have very outrageous expectations of medicine. So the more you have that expectation-reality mismatch, the more patients are going to suffer. So you do have to empower families. We have to engage and talk more about mortality, human frailty, what is appropriate care, what is not appropriate. Just because we can do a CT scan does not mean we need to. How is it going to change the care for this patient? How is it going to improve their care? And then I would probably end by saying that, you know, no cancer care is complete without palliative care. It's not possible to do one without the other. And I think that's already reflected here because you've invited palliative care to present at your conference, so thank you. These are the references. Yes, finished on time. Thank you.
Thank you for your presentation. Ladies and gentlemen,